Can a child have obesity and still be malnourished? The nutrition paradox of pediatric fatty liver disease. When we hear the words fatty liver disease, we often immediately think of excess calories, obesity, and weight loss. And when we hear the word malnutrition, we probably imagine the opposite, a child who is underweight and simply not eating enough. But what if both conditions can exist at the same time? What if a child can have obesity, excess fat accumulating in the liver, and yet still be deficient in important vitamins and minerals, consume inadequate protein and fiber, and even begin losing skeletal muscle? That is one of the central messages of a recent review published in the Journal of Nutrition and Metabolism titled Nutrition in Pediatric Metabolic Dysfunction Associated Steatotic Liver Disease, or MASLD. Today, we're going to look at what this paper tells us about nutrition in children with fatty liver disease and why treating the number on the scale alone may miss a much bigger metabolic problem. What exactly is pediatric MASLD? MASLD stands for Metabolic Dysfunction Associated Steatotic Liver Disease. In simple terms, this is a condition where excessive fat accumulates in the liver in association with metabolic dysfunction, and this is not a rare disease. The review reports that approximately 10% of children in the United States are affected, with prevalence increasing dramatically among children with obesity. In fact, the authors cite an estimate of roughly 1 in 4 children with obesity having MASLD. Even more concerning, the paper notes that more than a third of pediatric patients with MASLD may progress to the inflammatory form of the disease called MASH despite lifestyle treatment, while nearly 1/4 may have advanced fibrosis. So this is not simply a cosmetic issue, and it is certainly not just about body weight. The liver is undergoing real metabolic stress. So what causes fat to accumulate in the liver? One major dietary factor highlighted in this paper is simple sugar intake, and fructose receives particular attention. When large amounts of carbohydrate, especially simple sugars, reach the liver, some of that carbon can be converted into newly synthesized fatty acids through a process called de novo lipogenesis. Think of the liver as a metabolic processing plant. Glucose and fructose enter the plant. Some can be burned for energy, some can be stored as glycogen, but when substrate availability exceeds metabolic needs, the liver can redirect part of that carbon toward making fat. The review therefore highlights sugar-sweetened beverages such as soda, juice, sweet tea, and lemonade as important targets for dietary intervention. But here's where the story becomes much more interesting. The solution is not simply eat fewer calories. The authors argue that pediatric MASLD treatment should focus more on nutrient quality than calorie quantity. Why not simply put the child on a strict diet? Because children are not small adults. They are growing. They are developing bone. They are developing skeletal muscle, and their brains are developing. And they need sufficient energy, protein, vitamins, minerals, and essential fatty acids to support all of that growth. Aggressive calorie restriction may reduce body weight, but it can also introduce another problem, nutritional deficiency. The review specifically discourages routine calorie counting or severe restriction as a weight management strategy in pediatric MASLD. Why? Because restrictive approaches can negatively affect a child's relationship with food, are difficult to sustain, and may contribute to disordered eating or eating disorders. Instead, the emphasis shifts toward improving what the child eats: more fruits and vegetables, whole grains and legumes, adequate protein, more fiber, fewer sugar-sweetened beverages, fewer ultra-processed foods, and less saturated fat. That distinction is extremely important. The objective isn't simply to make the child eat less. The objective is to improve the child's metabolic nutrition. And that brings us to the paradox. Obesity and malnutrition can coexist. A child may consume plenty of energy and still consume inadequate amounts of essential nutrients. For example, a diet containing large amounts of refined carbohydrates, sugary beverages, and highly processed foods can provide substantial calories while providing relatively little fiber, protein, vitamins, or minerals. The review highlights deficiencies involving vitamin D, B vitamins, zinc, magnesium, selenium, and other micronutrients in this population. These nutrients are not nutritional decorations. They participate directly in metabolism. Vitamin D has connections with insulin sensitivity, immune function, hepatic lipid metabolism, muscle function, and mitochondrial biology. Magnesium participates in glucose metabolism and insulin signaling. Selenium contributes to antioxidant defense through enzymes such as glutathione peroxidase. B vitamins participate in pathways involved in energy production, methylation, amino acid metabolism, and many other cellular processes. So you could theoretically have a child consuming excess energy while individual cells are operating in an environment deficient in nutrients required for normal metabolism. That is the nutritional paradox. And perhaps the most overlooked organ in fatty liver disease is not the liver, it's muscle. The paper discusses an increasingly recognized phenomenon in pediatric MASLD sarcopenia. Sarcopenia refers to reduced skeletal muscle mass and function. The review cites estimates suggesting that approximately 20 to 40% of children with MASLD may have sarcopenia, although the authors emphasize that the definition of pediatric sarcopenia is still not firmly established. This matters because skeletal muscle is one of the body's largest metabolic organs. After a meal, insulin stimulates skeletal muscle to take up glucose. Amino acids stimulate muscle protein synthesis. Fatty acids can be oxidized within muscle mitochondria. So healthy skeletal muscle acts almost like a metabolic sink, helping the body handle nutrients arriving after a meal. Now imagine losing some of that metabolic capacity while simultaneously accumulating fat in the liver. That combination, excess adiposity together with low muscle mass, is often referred to as sarcopenic obesity, and it raises a very important question. When treating pediatric fatty liver disease, should we only ask, did body weight go down? Or should we also ask, what happened to lean mass? What happened to muscle function? Is the child receiving enough protein? Are they growing normally? The review specifically suggests that body composition assessment may be useful in children with MASLD because of the potential consequences of sarcopenia. So what diet works best? This is another area where the answer is not as simple as social media sometimes makes it appear. According to the review, there is currently no single diet proven to be superior for every child with MASLD. Reduced carbohydrate approaches have shown encouraging results. Mediterranean-style diets have also shown promise, but very restrictive approaches, including ketogenic diets and intermittent fasting, require considerably more caution in children. Why? Again, growth, nutritional adequacy, sustainability, and psychological health. A restrictive diet may reduce one metabolic risk while unintentionally creating another. The Mediterranean dietary pattern is particularly interesting because it does not depend on eliminating entire macronutrient groups. Instead, it emphasizes minimally processed foods, fruits and vegetables, complex carbohydrates, healthier fats, and reduced consumption of saturated fat and highly processed foods. So rather than asking, which macronutrient is the enemy, a more useful question might be, what overall dietary pattern supports liver health, muscle development, normal growth, and long-term adherence? There is also a psychological component we cannot ignore. Children with obesity frequently experience weight stigma, And once a child is diagnosed with fatty liver disease, there may be even more pressure from family, peers, healthcare providers, or the child themselves to lose weight. The review warns that excessive restriction, calorie tracking, elimination of food groups, or extreme exercise can contribute to unhealthy eating behaviors. Children and adolescents with MASLD may demonstrate behaviors including meal skipping, eating beyond satiety, eating in the absence of hunger, or nocturnal eating. This creates a difficult clinical balance. We want to reduce metabolic risk, but we do not want treatment itself to create an unhealthy relationship with food. That is why the authors emphasize family-centered multidisciplinary treatment involving nutrition professionals, medical providers, behavioral health expertise, physical activity support, and realistic goals that fit the family's social and cultural environment. And now there is another layer: weight loss medications. GLP-1 receptor agonists and other advanced obesity therapies are increasingly entering pediatric obesity management. These therapies can be highly effective, but from a nutrition perspective, appetite suppression creates an interesting challenge. If a child becomes less hungry and therefore eats dramatically less, what happens to protein intake, micronutrient intake, lean tissue, bone development, growth? The review discusses possible nutritional consequences associated with advanced obesity therapies, including inadequate calorie intake, dehydration, micronutrient deficiencies, sarcopenia, osteopenia, and gastrointestinal side effects. That means nutrition becomes more important, not less important, when pharmacological obesity treatment begins. The paper recommends strategies including smaller frequent meals when gastrointestinal symptoms occur, adequate high-quality protein and fiber, appropriate supplementation where needed, and monitoring of growth, body composition, and micronutrient status. So, what should we take away from all of this? Pediatric fatty liver disease is fundamentally a problem of metabolic health, not simply body weight. Yes, reducing excessive sugar intake matters. Yes, dietary pattern matters. Yes, physical activity matters. And for some children, pharmacological or surgical obesity treatment may also have an important role. But successful treatment should protect something equally important: normal childhood growth and development. A lower number on the scale does not automatically mean better nutrition, and a higher body weight does not mean a child cannot be malnourished. We need to think about the liver, but we also need to think about skeletal muscle, protein intake, micronutrients, bone, growth, mental health, the home food environment, food access, and the child's relationship with eating. Perhaps the most useful message from this review is that pediatric MASLD requires us to move beyond the simple equation of obesity equals excess nutrition, because sometimes the child has excess energy stored in one place while essential nutrition is missing somewhere else. And understanding that distinction may be critical for designing treatments that improve liver health without compromising the health of the growing child. Thank you for listening. If you found this episode useful, share it with someone interested in nutrition, metabolism, pediatrics, or liver health, and I'll see you in the next episode.